evening and welcome back to another edition of Let's Talk About Mental Health. I'm Nels Kloster. I'm a local psychiatrist.
And I'm Robert Stack. I'm a licensed alcohol and drug counselor. We've been doing this now for a little while, and we ask people, we try to be helpful and have people come in with questions and things that we can answer about mental illness and addiction. But we've had sort of limited in some ways. I mean, not a lot of people send us questions. And one of the things that we've been trying lately is to do a topic discussion. So one of the things that we thought we'd do tonight is talk a little bit about opiate addiction. And so there won't be any questions. If you have any questions about tonight's performance, obviously send it in, our email, and we can answer them again next week. But tonight we're just going to try and do a general presentation.
Right. And a lot of people are talking, there's a lot of attention being paid to opiate addiction, opiate dependency, and people use the term epidemic around what's going on now with, pills, prescription pills, heroin as well, although that seems a little less common in Vermont. But, one of the things we know is that there's a long history of opium. Going back all the way to ancient Egypt, like 4000 BC, they'd already discovered some of the healing properties of the opium poppy. They used it for dysentery, nausea, and for pain as well. So, while we might talk about having an epidemic these days,
right,
this is not a new epidemic by any stretch.
And when you read history books, this is they called it the soldier's disease after the Civil War. A lot of veterans were given opiates because they had the invention of the hypodermic needle. Now, it's kind of primitive if you looked at it, if you ever saw it, but that was the beginning of it. And then it went into sort of what they call patent medicine, sort of mail order. And I read once in the turn of the century, the most common opiate-dependent person was a white middle-class woman,
right,
who got patent medicine and opiates. But I think it's worth, just a small comment, I think it's worth saying that one of the concerns that we have, and it's really scary, is that here in Vermont, we are seeing more heroin. And people have sort of crossed that line. One of the problems that I feel that has been so scary is that we have young people that are almost naive about opiates. And as you know, there was that crossover point where people didn't normally, there wasn't great access to opiates, especially not in Vermont.
Right.
Most heroin addicts were East Coast phenomena, Boston, New York, Baltimore, Philadelphia, Jersey City. I heard once that you could put an arc around 125-mile radius around New York City, and that'd be 90% of all opiate addicts would be in that radius.
Okay.
And the other ones were in Chicago, L.A., and San Francisco, and New Orleans. And besides that, there wasn't that many. But one of the things that happened, and you can speak more to it, is that point where they decide that they wanted to treat pain more aggressively, and that there was more people prescribing opiates, and it was sort of suggested that they didn't have to worry that much about addiction when you do it properly.
Yeah,
Is that?
yeah. Oh yeah, I think that there are a lot of factors involved, and one of those is certainly that physicians have become more liberal about prescribing opioids. They did a terrible job sort of under-treating cancer pain, for example. People get what are called metastases, cancer that grows to the bones, a very, very painful condition. And realizing that there's really no reason to be stingy about pain relief for people who are at the end of their life with such excruciating pain. But then because of this under-treatment of pain, then we were pushed to recognize pain as a much more common or significant condition. And they even elevated it to the level of considering it like an additional vital sign, that whether you experience pain or not was equally as important as your heart rate, your blood pressure, that you're still breathing. And so there was a lot more attention. Are you in pain? Yes, I am. Then, well, the only treatment we know of is to prescribe opioids. And we started to chase after pain in the same way we chased after it when people had cancer pain, which is increase the dose, increase the dose, increase the dose, which when you talk about chronic pain, which is lower level of pain, which goes across the whole lifespan, that practice of using opiates and opioids only and steadily increasing the dose is not the best approach to it. We're not going to get rid of the pain completely, but then the dose escalates, and then of course we're helping to sort of create addiction with an approach like that.
And I also think there was like a generational shift. I mean, I sort of remember like in the 50s and stuff, there wasn't that many prescription meds. I mean, there just wasn't, and there was and I think the business of pharmaceutical companies sort of got involved, the business of selling drugs to make you feel better. And that's sort of valid. I mean, it's okay, but I can't help feeling that, at least in Vermont, when I first started working in the substance abuse field in Vermont over 30 years ago, there were very few opiate addicts. It was there. You could find heroin. It was around, but it just wasn't everywhere. It wasn't something that people did like to party. It was a certain group that had access to it. But I think one of the things that happened is that there's a generation of folks that feel comfortable taking pills, like taking pharmaceuticals, have gotten used to taking pharmaceuticals. And I know I shared with you earlier that someone said to me about taking Vicodins actually, and they said, well, I wouldn't take street drugs, but I take Vicodins because I know what's in it. And I don't think they really realize what's in it. I mean, yes, it's true, it's not mixed with some other horrible drug, but it's an opiate.
Well, like we were saying earlier, you know what you're getting, in that I know how many milligrams of Vicodin or how many milligrams of Percocet is in there, but you don't know it's like you don't know what you're getting into. And really how this is going to take over. And a lot of, I think there's a few things that have happened that have sort of decreased our level of concern, made us more comfortable with these with the opioids. And again, opioids, right? We have these opioid receptors in our brain, and there are all a number of substances that then sort of turn on the system, and gives us, some people it makes them happy, or makes you tired. You fall asleep, you nod out. You get pain relief as well, and constipation and these sort of things, sort of slowing down a lot of the processes in the body, like digestion and elimination. And so there are a number, when we say opioids, because I think we should probably mention that there are a lot of different opioids.
Right.
I mean, heroin is considered an opioid. They're kind of morphine and oxycodone and Percocet and Dilaudid and methadone and Suboxone. So when we use the term opioid, we're talking about a lot of different individual substances that then find receptors in the brain that are the same receptors, the opioid system. And if you talk about an exercise high, you get endorphins. You hear these stories about people, I was in the woods cutting down trees, fell on my leg. I had cut my leg off and take it to the hospital. And how do they do that? That's the endorphins that are kicking in, a sort of natural pain relieving system that we've then been able to employ with these medications that are much more potent and do the job much more effectively.
Right, but some of the clients, and one of the reasons I make a point on this, is some of the clients I work with, if someone said to them when they were 16 or 17 years old, do you want to do a bag of heroin? They would say no. No, I don't want to do any heroin. But if somebody said to them, do you want to do a Percocet? Maybe you want to do a Vicodin? I mean, they would say, yeah, sure, we'll split it, we'll snort it. And I think it's almost like this, in Vermont, and I think this is fair. When I was growing up, I met my first heroin addicts when I was like 12 years old, so that's like over 50 years ago. I know what it looks like. I know who they are. I know what it does to you. I think there were people in Vermont that were sort of naive about opiates. And they just thought it was, whether it's marijuana, there's cocaine, there's this, there's
alcohol.
There's alcohol, and, what's another pill? And this pill is okay, and it's sort of worrisome to me that sometimes I'll be talking to a young person and they're sort of thinking, oh, it's just this drug, I'm dope sick, and in my mind, it's like the wonderful world of Disney. You're in the wonderful
like a fantasy
world of
world,
opiates. You know what I mean? And it's like it's crossing the Rubicon. Now some people can sort of back off it, but I'm telling you, opiates are such a powerful drug. I mean, they make you feel good. If you have an empty dependency in other areas of your life, I mean, opiates will they won't take them away, but it won't matter anymore.
Yeah. When you were referring to soldier's disease, You know, first of all, we had the opium poppy, then we figured out, morphine and heroin, then we figured out needles and sort of to get those into the body more effectively. And Bayer used to sell a heroin product. You
Right.
used to be able to get, cocaine at the drugstore, over the counter at the drugstore. And there was a real problem, not just with middle class women who, whenever they sort of hysterical complaints, which meant anything to do with the reproductive system, they were prescribed opioids for that. So you had a whole lot of women, particularly, that were opiate dependent, and kids were getting into opioids with the beginning of the industrial age. Miserable work. You're putting people in factories, you're essentially treating them like machines. If you're not working, you're sleeping. And they were using opioids very heavily back then to sort of numb that miserableness to their lives.
I heard smack was actually a word. It was a Yiddish word that was used in in Manhattan, where they used to make clothes. I forget what the term is. They have a word for it, but that's the origins of the word smack, which is what I grew up with knowing about. But so there's like two avenues, and I don't want to spend time on this. There's like two avenues to get there. One is this traditional getting high. I want to take something, I want to do a substance that will change the way I feel, make me feel better. That's
I want to feel
enjoyable.
good, I had a bad day, God, I just want to do this thing. I had a good day, hey, let's make this even better. Let's sort of, minimize the negatives and sort of accentuate, build up what's going well.
So we have the young people sort of getting involved with that in their 20s, getting opioid addicts. But also, and you have also, I know this, worked with men and women who got into opiates through pain medication.
Right.
Now, it's really clear to say not everybody who gets opiates for pain medication becomes addicted to opiates.
Right.
But there is a risk factor. And there are people who do. I mean, they really like it. They really enjoy it. And they feel they're not getting enough.
Right.
And these are honest, moral, good people who find themselves going into the doctor saying, I ran out. Could I have a little more?
Right, yeah, my dose isn't high enough.
My dose
I'm
isn't
still
high
having
enough.
pain.
I mean, they are finding such relief and comfort in it. And I think they too struggle with this idea, well, I'm not a drug addict. I don't want to be a drug addict. And even young people I talk to don't really want to be a drug addict. That idea is...
I'll get that at the methadone clinic a lot. Dude, I'm a pain patient.
Right.
I don't belong here with these other people. Right, it's different for me. The doctors did this to me. I have this pain. I had these back surgeries. I'm not getting better. They kept prescribing this for me. But it really ties into just how powerful these medications are. Because whether you want to call yourself an addict, which brings in a whole scope of behaviors or ways of getting your drug and ways, the lying and cheating and stealing sort of things, that even people take lower amounts of opioids for a shorter period of time, maybe weeks or a month, after surgery, they will still talk about withdrawal because their bodies have developed a dependency. The way their opiate system works, the way the receptors get filled with the medication, there are some changes to sort of how many receptors, how they sort of interplay on the membranes, that then when you don't have that substance cause discomfort. What you call withdrawal, or in the street language, dope sick.
Right.
So it doesn't take too much for that to happen.
Right, and I think it's sort of worth sort of acknowledging. We don't want to call people names. I mean, I don't want to call anybody a name, but you'll get to a point where the opiates are starting to move further and further into the center of your life.
Right.
I mean, it becomes, you can't imagine, you need it every day. And you'll find, and this happens with heroin addicts, this happens with people who are workers, who have pain issues. They just say, I can't get through the day without it.
Right.
I'm not getting high, but I need the drug, and I actually find out I need more. And I'll tell you one thing I've noticed. Some people who take opiates for pain, the opiates are so powerful, they do things they shouldn't be doing. Mm-hmm. They'll lift things, they'll work in a certain way, and they won't take care of their pain. And I know you said on a previous show, there's a reason why we have pain.
It's a signal.
It's a
signal to us.
That's right.
My back's saying, you've hurt me. Stop it. Back off.
Don't
Don't
do
lift
it.
that thing. Why don't you go sit down? Why don't you go lay down for a while and let me heal?
And so now you see people on opiates who are actually hurting more, and again, taking more of the opiate. And I guess again, I want to be really careful. I was sitting in the doctor's office and one of those little rooms that you wait in, and they had a sign on the wall and it said, if you're in trouble with opiates, let us know. Well, that's a nice idea, but if
so we
you're
can
in
stop
trouble with
prescribing for you, right? Which is
I
the
know.
last
I mean, because
thing
it's
we
really
wanna hear,
scary.
yeah,
Because
yeah.
you get to a point where you say, I can't imagine being awful.
Right.
I tried it a couple times. You were saying before the show, I've got real sick. I was good for a couple of days without it, and then finally I just said, I can't be sick anymore.
Yeah. I mean, if you think about the withdrawal symptom from opioids is very much like the flu. You have aches and pains, you have sweats and chills, you've diarrhea, you're uncomfortable. Some people get headaches with this as well. And I think that's one way to get a little bit of empathy around just what this means, is that when you have significant withdrawal, it's like you have an awful flu every day, or even many times during the day. And I mean, if you had the flu, they kind of go to bed under the covers, I can't do a thing because I feel so bad, you wouldn't take a pill to make that go away.
That's right.
If we called it an antibiotic, you'd say, okay, yeah, give it to me.
That's right.
But in this case, so it's keeping the opioids going, keeping on using those, that then takes away all that happens to this body when the opioids are not in it anymore.
And I think, and I might have already said this, I think in some ways, people who have other issues or other things going on, all of a sudden all their dependencies get rolled into one dependency, and that dependency is getting the drug. And if you've ever felt that, there's a certain relentlessness about getting the drug. I mean, when I worked with clients in the hospital, they would get angry at you for not giving it to them, or they weren't getting enough. I mean, they just felt like, you have the ability to make me feel okay, to meet my needs, and you won't give it to me. And they get furious. I mean, they get like, not in a mean way. I don't want to present them as being mean, but it sort of becomes a driven. And it becomes something that, I need to accomplish this on a daily basis. I need to get enough, which there never is enough. Mm-hmm. And it becomes a good day is a day I got drugs.
Right.
I
read a book called in the Realm of the Hungry Ghost by a guy named Gabor Mate, who's a addiction, I think an internist up in Vancouver, Canada. And that idea of the hungry ghost is a reference to Buddhism, where you talk about the sort of suffering that a lot of people have, and it's just this insatiable emptiness that just can't be filled. And so, of course, they're not necessarily mad at us, and they're not necessarily mean people or any kind of negatives that we might want to describe them by. But there's just such that gnawing and emptiness that can only be satisfied by a return of the opiates to the brain.
I hope this is scientifically okay for me to say, but I think the addiction becomes two things. I think it becomes a spiritual illness. I think it becomes a physical illness. I think on some level it becomes both of those things are going on. And that's why I think some people just really, really struggle. It's not just, gee, I need this drug because if I don't have this drug, I'll be dope sick. Well, that is true. But I also think there's more to it than just that. I mean, at least
I think that's fair.
The folks I've been working with.
And some people might think, right, this is a plug for 12 steps, it's a plug for AA with the new spirituality. There are many different realms for health, and like Alice Scudder, who we worked with. There's physical health, there's mental, there's emotional, there's also your spiritual health. We are, spiritual beings.
Right.
And absolutely, if all you're doing is chasing after a drug, then the relationships are gone, work is gone, spirituality is gone, physical health is gone. And absolutely, it's a very big piece of this.
And I think one of the tragedies is usually by the time you get done with opiates, you've lost everything. Yeah. Now, some people, for whatever reasons, whether it's their job or something, or they have access to money or drugs, but for most opiate addicts, at some point they pay a tremendous price for that drug. Yeah. They lose family, they lose jobs, they lose their respect, they lose many, many things. I mean, it's sort of... And that's the saddest thing, is that by the time you really come and you say, I want to get better, you often, it's toward the end. Yeah. I mean, you've lost everything else, and you have to build that back.
I used to have this idea when I started out. It seemed like, especially, I'm working in Suboxone clinics, working in methadone clinics, that it seemed like when people said, okay, I want to get clean, I want to stop this roller coaster, that something always happen, something major. And I used to sort of talk to patients about, it seems like the gods throw down a challenge that, oh yeah, you want to get clean? Here you go, see how you get over this. But as I've done this work a little longer and get maybe more grounded in it, you've ignored so many things for so long that all these things you've let go, your health, your relationships, trouble is waiting for you. And when you finally then get yourself sort of stabilized, whether it's from a medication, whether it's from sort of long-term treatment, and then you're aware and you're present, then you realize, oh my God, look at this mess that's all around me. How am I ever going to fix all this up?
And I think that's what I've seen has been so successful, is that some folks get on medication-assisted opiate therapy, which is primarily usually methadone or Suboxone. But what works nice is that if they're on the medicine, they're still involved in some aspects of recovery. They're still, whether they go back to school, they get a job, or they get stabilized, or they get housing. It's not just that they're getting this medicine. It's not just that they're not dope sick. And I know I've said this before, but it's like Dr. Kane used to say, this medicine will give you a platform for you to get better on. Because I don't want you to get any worse. You know what I mean? I don't want I don't want you out there. I don't want you breaking the law. I don't want you getting HIV or Hep C or whatever else happens when you're out there. But at the same time, this is not, getting another drug, getting this medicine should not be considered the end game. It should really be considered as the beginning of working out this program of recovery that's going to involve medication. So.
Yeah, because I think we've seen a lot, maybe it's a good time to explain just what we think about with medication-assisted therapy, but I have run a lot of people who make the gaining a place in a Suboxone program or getting that prescription to be their goal, when really it should be a tool towards some bigger goals of getting well. But what we noticed, and this can be talking about right back in the day, 90% of your addicts, opiate heroin addicts, were within the radius of New York City, which is where they started initially with Dr. Dole in the methadone clinics. It was in New York City. Yeah. And the idea was that you take like heroin, which was the prominent opioid back then, and it's so fast-acting, and especially if you're injecting it, it's on, it's off, you're up and you're down, and all day long you're chasing after that because, again, you're going through this very intense flu many times during the day. And what they found was with methadone, which is a long-acting opioid, that once you're able to sort of get that into the opioid receptors, then they were calmed. People who are in withdrawal from opioids, I often just sort of describe it as you have angry opioid receptors, sort of like that movie Little Shop of Horrors, with a man eating plants. See, he got bigger and bigger and bigger. That's what your opioid receptors are like. Right. And by filling these with methadone, which is a long-acting medication, we can control then how much you're getting. It's more stable in the bloodstream and more stable occupying the receptors. So we have then the body's taken out of the equation. So you're no longer being driven to relieve yourself of this awful flu, but you have a medication then that allows you to feel normal again, is what people will say. Right. And then once you're normal, then the work starts. Then you start to look at the wake behind you, so the wreckage of your life that has piled up while you've been using and unable to stop because it's got to the point where you need this. It's not something you want to do anymore. It's got to the point you need to do this to not be ill. And
I think one of the problems, as you know, methadone was started with Nixon for the war on crime. I mean, that's how he got elected, a war on crime. And he had Vietnam veterans coming back who had been exposed to heroin, and there was some concern there. But it was really about stopping property crime. And they thought, we can begin. And I think that's one of the problems with methadone, is that it became more of the benefit for society, which is still true. Mm-hmm. But it wasn't really done in a way, I think, that was respectful of the addict. And I'm glad to say that, your involvement with the methadone clinic in town here. But it's really, I'm hoping that more and more people will realize that methadone and Suboxone, buprenorphine, is a medication that we're using. Now, there's a lot of controversy about it, you know what I mean? But really, I think on some level, you have to know the person. I mean, if you, you know what I mean? Like if you knew an addict and you knew someone who was going through what they go through for when they're addicted to heroin or opiates, and you realize there's a medication that can stabilize them and make their life better, make so many things possible.
There,
Go ahead.
There are people at the clinic or my Suboxone practice who you see them around town. They have jobs.
Yeah.
They're performing well. They're starting to have families because they've gotten their addiction under control. So, babies are being born, couples are happy, people have productive jobs.
Right.
And that's really gratifying.
Right.
Because on the one hand, like you said, the big sale for this, and what I say this too to groups when I'm talking, is that it's money well spent. The estimate that's been around for the longest time has been for every dollar spent on methadone treatment specifically, there's about a $4 payback. And it's thought that the stronger statistics around decreasing crime. I even saw a study that showed that the areas around methadone clinics have less crime than do areas around liquor stores.
Right.
So there's definitely helpful there. So I'm protecting I'm protecting your house, your car, your family, your kids' lunch money. All these things by having methadone clinics and opioid treatment. I mean, healthcare costs. If you're not injecting anymore, you're not getting those sorts of infections, or God forbid, even your cardiac, heart problems because of that. Then that happens, and not to mention the productivity that comes. People get jobs, they contribute, they're able to buy cars, houses, and provide services in the community. And so that's sort of what gets people thinking, okay, this is money well spent. And then there's that personal piece that once you get to know the opiate addicts and work with them, you start to like them.
Right.
And then you realize, it's valuable just from that perspective.
Time is going by, and I'm gonna give away my age here, but I started working in this field, and wasn't any methadone in Vermont. There wasn't any Suboxone, there was nothing. And so when we dealt with opiate addicts, what we could recommend to them was NA, Narcotics Anonymous, or AA. And in Vermont, because of its rural character, there wasn't a lot of NA. There is more now. There are more meetings and stuff. And there are people who put down opiates, get into Narcotics Anonymous, or get involved with Alcoholics Anonymous, and get better. I mean, once you've been in opiate, sometimes when you put it down, you never go back to it. You realize how horrible it was. You realize how negative it was. And we were talking about this. One of the problems that some people don't recognize is that addiction has different levels of severity. Some people can walk away with no help. Some people need a little bit of help. But some people have really severe forms, whether it's biological or chemical or neurotransmitters, whatever it might be. You have to be careful that you don't assume that this is what works for this person, so it's going to work for everybody else.
Right, one size fits all.
No, not at all. And it's not even going to work the first time out. Right. I mean, you could try 4 or 5 hospitalizations before you finally get that right mix of dedication to recovery, dedication to medication, a decision not to want to get high anymore. I mean, one of our big problems with Suboxone clients was they were using other drugs, and then the doctor would UA them and then drop them from their service. So, I mean, we've used up the time pretty quickly here. We didn't talk too much about treatment, but there is treatment. So we never know what audience we're talking to. So if we're talking to an opiate addict, please get help.
Yeah. And I mean, that's maybe too to ask for feedback. We've been doing this show for a couple of months now, and we're often where I buy my donuts in the morning. She gives me comments. I ran into somebody in the co-op the other day. Patients will say, "Gosh, you guys are on TV all the time." Call, leave messages, the texting. We'd like to know, what do you like, what don't you like, and what would you like? Because we can sit here, we've been talking to each other like this for like 4 or 5 years now. By all means, this is not about us, so any kind of suggestions, we would really love to hear them.
And there's more. I mean, this is not rehearsing, this is not tape, and it's sort of live. So, I mean, there's so many other things that we could talk about as far as treatment, about 12-step programs, about medications, about any number of things. So if you have any questions at all, please contact us and we'd be more than happy to answer it. Thank you.